Some indications for prone positioning would be to improve ventilation and perfusion matching and to improve oxygenation issues. Okay, so now we're going to go over some exclusion criteria. Some are do not resuscitate orders. So if they have a do not resuscitate order, you do not want to perform a prone position. Asthma, head injury that is related to raised intracranial pressure. Patients experiences seizures, spinal injury, recurring spinal precautions, spinal instability, osteoporosis, recent abdominal surgery, recent stoma formation, open abdomen, large abdomen, pregnancy, especially if you're in the second and third semester, open chest, right ventricular assist device, left ventricular assist device, intra-aortic balloon pump, recent cardiothoracic surgery, an unstable mediastinum, recent cardiopulmonary arrest, a new trach has been placed inside of your patient, multiple trauma, external pelvic fixation, maxillofacial surgery, recent pelvic or chest fractures, acute bleeding, traction, advanced osteoporosis, rheumatoid arthritis, a history of poor tolerance of prone positioning, a hemodynamic instability with a mean arterial pressure that's less than 60 millimeters of mercury, if their weight exceeds 135 kilograms, and if the person has kyphoscoliosis. Thank you. So let's go over some preterm considerations. If following consideration of the exclusion criteria and risk assessment, the patient is a suitable candidate for the use of prone position, the following measures should be undertaken. Pressure area risk calculated in assessment made for use of specialist mattress as per intensive care unit standard. Eye care. Maintain eye closure using gel perm or tape to avoid corneal abrasion. Mouth care. Suction all excess fluid from the mouth and the oral pharynx. Check the pupils equal and reacting to light accommodation before and following the turn. You want to insert closed suctioning equipment, date and change per product guidelines. You want to check all central venous and arterial access sites for inflammation, need to change. Wound dressings required on interior aspect of the body to be performed. Ensure that the endotracheal tube and tracheotomy tapes are checked to ensure that they are secure. You want to make sure that they're secure, because if they're not secure, then it could cause a withdrawal from the ET tube, and you definitely do not want that. Tracheotomy care and dressing change according to the unit and or trust guidelines. You want to ensure chest x-ray is taken if ordered. You want to document grade intubation and length of ET tube at the teeth. This is to ensure that the correct placement of the ET tube is still at the needed centimeter. There are several ways where you can place your patient in a prone position. So I'm going to show you a few techniques. So today we're going to perform positioning a patient that is in supine into a prone position. So our technique is that we're going to have Nurse Mackenzie here. When I roll him over, this is our patient Aiden. She's going to place a pillow under our patient Aiden. So Here you go, Nurse Mackenzie. I'm going to roll Aiden to his side, okay? All right, and you put the pillow under Aiden. And so Aiden is now on the pillow. We're going to place him on the pillow. We push it up under him. Okay? So she's going to help me pull the sheet out. Okay? Okay, Mr. Aiden, let's stay on the pillow, okay? This is going to be a fun demonstration. All right, and so then we're going to place a sheet over Mr. Aiden. And then Nurse Mackenzie is going to roll up her side, and I'm going to roll up my side. And then we're going to turn patient Aiden onto his side, onto his stomach. So now patient Aiden is in prone position. So we'll take off the top sheet. And he's in prone position. So that's how you would put a patient in a prone position. Thank you. So it was me and another assistant, but if it was a real life situation, I would have had 3 people in the room to help support me, because if my patient had an endotracheal tube in his mouth, I would have had that 3rd person to secure the endotracheal tube, and the other 2 would be the ones that are rolling up the sheets and putting a good grip on them. So you want to make sure that you do place a pillow under your patient for support before you place them in a prone position. So at first I demonstrated how you could place a patient in prone position manually. You can also place a patient in prone position mechanically. I'm going to show you now. This device is a rotoprone, and it mechanically turns the patient into prone position. So now we're going to talk about monitoring the effectiveness of prone positioning. The patient is nursed in the prone position. If oxygenation improves for up to 20 hours per day, providing oxygenation does not deteriorate and the patient does not demonstrate signs of discomfort, the patient is then turned supine to allow for appraisal of the following issues by clinicians during the multidisciplinary ward round: response to prone position, occurrence of pressure sores or increased risk, eye and mouth care. This is still undertaken in prone position, but it is realized access is difficult and therefore sculptural attention is paid to these areas when the patient is in supine position. Physical assessment by the attending medical consultant and physiotherapist on the ward round. Joint mobility is also evaluated by physiotherapists. So we're going to talk about how to prevent some scan breakdowns. Specifically, we're going to focus on the head and the neck. Be aware of the patient's natural posture. They may have a fixed kyphosis or a condition such as rheumatoid arthritis or cervical spondylosis. The head of the bed may be elevated to try to minimize facial edema. In principle, the head should be placed in such a position that the neck is not extended and the head supported by the mattress alone. If the use of the pads for the head support is to be considered, this must be discussed with the physiotherapist prior to placement. So we're back again. Let's talk about some passive movements and limb positioning while in prone position. There's little literature available to guide us concerning passive movements and limb positioning. It is known that stimulus for soft tissue deterioration is lack of movement. Muscles also become shorter and stiffer, leading to impaired function. If joints are difficult to move, forceful movement may cause micro tears in the muscles and other soft tissue structures around the joint. Torn fibers will bleed, which may result in calcification. This form is heterotrophic ossification, produces further loss of mobility, making movement extremely painful. This does not respond to intervention. Conversely, overstretch of soft tissue may also lead to symptoms resulting from adverse neutral tension and damage to connective tissue. Thus, it is important to maintain soft tissue length and mobility within normal range of movement and normal resting postures. There is no literature to suggest how often the patient position should be changed or how often limbs should be moved passively. Patients in intensive care are usually turned every 2 to 4 hours to prevent pressure sores from developing. In the absence of evidence to support other regimens, we suggest that the prone patient should also have their position modified every 2 to 4 hours. Before considering any trunk, spinal, or limb position, the premorbid pathology in these areas should be considered.